Hey, deserving listeners. When I started out as a therapist in the mid-90s and I started learning about ethics, I thought that ethics were a set of rules that us therapists were supposed to follow. And I kind of wanted it that way because then it would be easier to know what to do. Like, in this situation, you're supposed to do this. And in this situation, you're not supposed to. Or you're never supposed to do X, Y, and Z. Like a common one would be never accept a gift or a tip from a client. That kind of thing. And as I progressed into my career, and particularly as I became a professor and a supervisor myself, I kind of slowly realized, because I didn't really have proper guidance around this, or I'm just slow to learn this I don't know, but I slowly realized over this span of years, honestly, that ethics and ethical decision-making is a complex system of various different considerations, like the standard of care and consensus and how you can justify certain actions, your process, like you can do something that is harmful to it. How do I word this? If you take actions that result in the harm of a client, but you went through a very rigorous decision-making process, then on average, it's more likely that you're not going to be considered liable or having committed an ethical violation, even though harm happened to the client. Whereas if you do the exact same harm to a client, but you just decided on your own, you didn't consult with others, you didn't think about it, you didn't document your decision-making process or or the pros and cons, that kind of thing, then you will on average be found more likely to be, you'll be more likely to be found liable or having committed an ethical violation. Just things like that. Also understanding different pockets of research and thinking within my field, because within the field of psychotherapy and mental health, there's a lot of pockets. There's a lot of individual silos, if you will. And the consensus can be hard to determine when you have all these different groups of people in my field. But when you have an understanding of that, then you have an understanding as to one of the factors involved in decision-making, ethical decision-making, not only just as a principle to follow for yourself, but also what will hold up in a licensing board hearing or in a civil case or even a criminal hearing. So I slowly started to learn that. And one of the things that I slowly started to realize regarding ethical decision-making is understanding how these cases are actually adjudicated in court or among lawyers or in the licensing board hearings. And just so you know, the typical end result of the question as to whether or not a therapist has committed an ethical violation happens in two main venues. One is in the licensing board, which is a government agency or an agency that has been designated by the government that will oversee the licensing of clinicians in the jurisdiction. In my country, it's in Washington, it's state by state. And the licensing board can take away your license or sanction your license in some way or put you on probation, that kind of thing. So that's one end result of an ethical violation. Another is in a civil case where a plaintiff sues the therapist and a court or a judge or a jury, a trier of fact, determines whether or not the therapist did indeed commit an ethical violation that resulted in harming of a client. There's other kinds of legal suits. Anyway, so those are the two main end results. And so when we understand what actually happens in those two venues, then it, of course, helps us to understand what we should do day by day, hour by hour, session by session, client by client. And yet, what I find is that these rulings in courts and in the licensing board hearings are almost never made available to us therapists. It's embarrassing how long it took me as a clinician to hear, I mean, just from my own memory anyway, of my very first actual court hearing or licensing board hearing. The typical conversations that happen, and I see this today as well, is you'll have a bunch of therapists that will talk about whether or not something is ethical or not. A very common thing that happens today is on Reddit, someone will post a question and say, is it ethical or unethical, this or that? And the different subreddits on Reddit, I don't know the exact names, but I've seen them where it'll be a group of therapists or it'll be a group of clients that are talking. And there will be these questions that will be raised. And for sure, some of the comments below some of the answers to the question are what I believe to be intelligent and informed, but many of the responses are not. And that is typical. Therapists aren't really told or given access to good information or where to even look for good information. Because again, these decisions and these quote unquote rules, and they're not rules, but these guidelines are made a little opaque to us. I mean, we have our ethical codes, and if you look at our ethical codes and you understand them, whether you're a psychiatrist, psychologist, marriage and family therapist, counselor, social worker, psychiatric nurse, those are all the main professions. Each have their own ethical codes, but generally they're very, very similar. And when you read them and you really understand them, they don't really tell you what to do. They're pretty broad and brief, and they don't provide explanations. I mean, there are extra literature and explanations that will provide that, but it's not easily understood. And if you just understand the code, you just read the codes because they're pretty clear. So I personally follow both the American Psychological Association Code of Ethics for psychologists and also the AAMFT for marriage and family therapists, their code of ethics as well. I also generally will consult with the ACA, American Counseling Association Code of Ethics, because it's I like to absorb all that resource. But just looking at the APA, the Psychologist Code of Ethics, an example of one that is very clear, maybe the only one that is very clear, is the following. Psychologists do not engage in sexual intimacies with current therapy clients/patients. That's it. It's probably the shortest ethical code. Usually they're paragraphs. Psychologists do not engage in sexual intimacies with a current therapy client. So what about right after you terminate? So you terminate that week, and then the next week, now you can have sex because it says current, right? And of course, there's a lot of other literature around this. But anyway, so that's the only one that is really clear, but just looking at some others. So another category of ethical guidelines and codes has to do with what we call multiple relationships or dual relationships. And in a nutshell, one way of demonstrating this is that if I am treating a client, I have one relationship with that client as therapist and client relationship. Let's say that I also have a child that goes to the same school as my client's child, okay? So that's another relationship that I have with the client. In addition to the therapist-client relationship, I also have a relationship with that person in that we're both parents of kids who go to the same school. That's pretty distant in terms of relationship, but it's a relationship. We might run into each other. There might be required meetings or assemblies at the school that I undoubtedly will be in the same room with that person. A more commonly discussed multiple relationship might be something like if my uncle went to school with my client or something like that. Or one of the problems that therapists will head into is if a therapist were to hire their client to do something. Like they might hire their client to do landscaping or hire their client to do babysitting or something like that. So these are other relationships with clients. And a lot of people will claim, and I've heard this, that any multiple relationship is inherently unethical and is against the rules, is unethical. But that's just not true. You can engage, well, it's not a matter of can or can't. It's a matter of many multiple relationships that clinicians engage in are not found to be an ethical violation, in that the risks are not severe enough to justify passing up on the benefits. That's here I would say that it's not like do this or don't do that. Anyway, so just reading, and this is a number of paragraphs, but just reading sort of the main part here is that a psychologist refrains from entering into a multiple relationship if the multiple relationship could reasonably be expected to impair the psychologist's objectivity, competence, or effectiveness, blah, blah, blah. So a psychologist refrains from entering into a multiple relationship if that relationship could reasonably be expected to impair the treatment, impair the psychologist's ability to treat the client. Well, what does that mean? Reasonably could reasonably be expected to impair. That's not clear. Who decides what's reasonably expected to impair? There's a lot of wiggle room there, and there's nothing in the ethical code that says this sort of multiple relationship is guaranteed to impair, whereas this one might be more of a gray zone. It's case by case. So, for example, in small communities where there's not a lot of people, it's well understood in my field that it's really hard to avoid multiple relationships. Like if you're one of the only therapists in town, or you're the only therapist in town, or you're the only therapist who specializes in something, and let's say you have a client that comes to you, and that client happens to be the only dentist in the area, and you need a dentist. So what are you going to do? You're going to drive 3 hours to find a dentist? Is the dentist going to drive 3 hours to find a therapist? Now with like online therapy, it really kind of throws a wrench in this. But it could be argued that for some people, online therapy just isn't going to work or isn't preferred. Anyway, so in that instance, if I am in this small town and this person comes to me and they happen to be the only dentist, and then I hire the dentist to be my dentist, that's a multiple relationship. It's pretty interesting, right? It requires a lot of thought. Now, it's not like small communities are completely off the hook. There are, case by case, there's a lot of things you have to consider. And if you engage in that multiple relationship, you have to do a lot of things to ensure that the client won't be harmed or that the risk is kept to a minimum. The client, of course, has a lot of say in the matter. So in that instance, I would have a client that I see weekly, and then every 6 months, I go to my client and they put their hands in my mouth and do stuff. It's a multiple relationship, and it's well understood that is a consideration in these small town situations or in specialty situations. So these are not rules; they're codes, they're principles, they're guidelines, if you will. They're considerations, and again, one of the main things that is not provided, at least to the people in my circle, is, okay, when you finally get to court or the licensing board hearing, what exactly happens? Because then we could work our way backward, and it'll give us another tool to use when we're trying to decide what we're going to do. Oh, here's what I'm going to say. So a lot of people, in my anecdotal experience, therapists, clinicians, when they're talking about what is and what is not ethical, is often I find, once I became knowledgeable about what actually happens in court, is that there's this sort of weird echo chamber among clinicians where everyone is just making shit up, essentially. And I'll hear them talking amongst themselves, or I'll see them talking online, or I'll be in a meeting where people are talking, and I'll think, well, based on my knowledge, 'cause eventually I really just set out to become a lot more knowledgeable. And one of the things that I did was I started to look into these actual case studies, but also I would consult with lawyers, and I would have lawyers on the podcast since the early days. And hearing them talk, because they are involved in these court hearings and these licensing board hearings, and hearing them talk, it's very eye-opening. Because lawyers, if they're experienced and competent, particularly if they work in mental health cases, they understand that it's nuanced. Like, one of the most classic things you're going to hear from an actual expert regarding an ethical choice, if you were to go to them and say, okay, I did this thing, was that ethical or not? And what the expert will say is, well, it depends. Let me ask you some questions. And then as you provide more information, the expert might say something like, well, I understand your decision-making there, but you could be liable if this happens. And if the court sees it this way, then that could be a problem. Plus, there's this unknown, it's very amorphous. And at first, this really bugged me because I thought, shouldn't we just have some fucking rules about this? And then we could just put it to rest and know what to do. Like the classic that I remember was in graduate school in the mid-90s. I don't know if I asked the question or someone else did, but a case was brought up. And for those who know my small community, Ned Farley was my ethics instructor. He still teaches at Antioch today, a friend of mine now. And he was giving a case in which you have I think it was Ned, anyway, in which you have a teenager who you're seeing in individual therapy, and she discloses to you that she is using cocaine and using it fairly often. So confidentiality guides us regarding, post 13 and above in my jurisdiction, that the child has confidentiality, that you don't tattletale on the kid. You don't tell the parents. That's the question mark. Do you tell the parents? And of course, the answer is no, of course not. This is a confidential relationship. You don't blab this information. It's one of the central principles of our profession. And it's clearly laid out in the ethical codes and in the case law. So I thought that was the answer. But then the professor said, but let's say that this teenage girl uses and dies from it. And then there's an investigation. They pull the file, the parents or whatever, or somehow the parents find out that you knew about the cocaine use in this teenage client. And then they sue you. And I'm thinking, well, obviously the answer is the parents would lose that case. My professor said, no, the parents might win because they could argue and could convince a jury or the judge, depending on who's the trier of fact, that you should have informed the parents that there's a certain level of risk and danger to life that it's expected that we should try to reduce the risk of a client dying, and that might actually involve breaking confidentiality, such as informing the parents about the drug use, that kind of thing. But it really depends on the situation. Maybe you suspected that the parents were abusive, or maybe, on the other hand, you knew that the parents already knew about it because there's enough evidence from the client that says the parents already knew, so you don't really need to break. So when I heard that, I said, wait a second, wait. So you're saying that if I have a teenage client that is telling me that they use cocaine, and I say nothing because I'm preserving confidentiality, then I could be sued successfully by the parents. Is that what you're saying? The professor says yes. On the other hand, if I do break confidentiality and tell the parents, the teenage daughter could sue me successfully for breaking confidentiality. Is that what I'm hearing? Professor says yes. And I thought, that is fucked. That is a stupid ass system. How do we have a system? Yeah, and the other factor here is that us mental health people, we don't get sued very often. Thus, the case precedents are not numerous. So we don't really have that to go off of. And when these cases do end up in court, the judges or the juries don't have that to go off of either. So a lot of these cases are, one, they never end up in court or in the licensing board hearings, but two, if they do, they might be the first of its kind. So all this is leading me up to the following, which is that this morning I received an email from my malpractice insurance. It's a newsletter, and it had an actual case that my malpractice was working on and had worked on with another insured mental health professional. And they type it up, and it's anonymized, and they provide it as a learning tool for us who have this malpractice insurance to learn from. And I love these cases. And if you've been listening to this podcast for a while, you know that I've always liked these cases. Whenever I get them, I probably get maybe 5 a year or something from my malpractice. And whenever I get one, I almost always talk about it on the podcast because it gives me an opportunity to sift through it myself, but also I just want to get the word out to people, not only to therapists so that they can understand, but also to the public, that you understand what your rights are and what is good therapy and bad therapy. And that if you're being treated poorly or in a way that is risky, I think you should know that. And clients almost never know that they're being mistreated, or if they suspect they're being mistreated, they almost never know what to do. So these cases, I think, are important for a number of reasons. One is for therapists to learn so that they don't commit these mistakes. Because the vast, vast majority of therapists are not trying to make a mistake. They're not trying to cut corners. They care deeply, but this is anecdotal, but a majority of therapists and counselors, psychologists just have not been educated or supervised well, and they don't know where to turn. So, this is why for me in my career, it took me a while to realize this. And once I realized it, I was like, oh crap, I'm a supervisor. I'm in charge of this sort of thing. I could be sued if one of my supervisees does something that I should have done something about. Plus, I don't trust any education system to inform my supervisees, so that's on me. And one could argue that that's the ethical way of looking at it, that if I'm going to be supervising somebody, I can't blame their training program. I can't say, well, they should have been trained that. The buck stops with you. And that's why I take supervision and always have. I take it so seriously, such that up until this point, the only book that I've ever written was about supervision. It's a very, very passionate topic of mine. It's not just checking on their progress notes. It's a deep relationship that involves not only a supervisor that fully understands how to detect and investigate and inquire about ethical situations with their supervisees, but also how to guide people, how to teach people around that. Not only that, but also the deep mentorship relationship that happens between a therapist, between a supervisor and a therapist. One that, for me, the 2 or 3 high quality supervisors that I've had, and I've had something like 17 or 20 supervisors in my career. It's common to have a lot of supervisors, particularly with the way my career went, because I basically have 2 professions. I'm both a marriage and family therapist, and I'm also trained as a psychologist. So you're going to get a lot of supervisors, and a small minority of them, looking back, I consider to be actual supervisors, and the rest of them were mediocre or downright abusive. And that is what research shows, is that there's a bell curve of supervisors with most in the middle mediocre zone. And you have a few at the high end that are doing their job and take it seriously. And then you have a few at the low end that are abusive, harmful to the supervisee. That's absolutely my experience. I have absolutely been abused by supervisors. It's unfortunate. So I want to present this case that I got this morning. I got it, and I didn't plan on doing this today, but I started reading it, and I was just getting so into it. I thought, well, shit, if I've got it sort of downloaded into my head, I might as well yammer about it on the podcast. So let's get to it. And this case has to do with supervision. It has to do with all the typical things. And it's an example of a therapist, a counselor, a supervisor, and an agency that all get sued successfully for dropping the ball in a very, very severe way that resulted in a very dire consequence for a client. So let's get into it. But first, let's take a break. And then when we get back, we'll get into it. All right, we're back from the break. So this case brief comes from my malpractice insurance company, which is called HPSO, which I think is Healthcare Provider Service Organization. And a lot of what I'm about to read is verbatim from the brief, but other statements in here are my own embellishments. So just keep that in mind. All right, so this case involves an agency and an agency owner and a supervisor and an intern and a client. Okay, so getting into the brief. The agency had a contractual relationship with a local university to provide training and supervision for interns and a counseling program. All right, so just to provide an explanation of what they're saying here is that you have a university training program that trains therapists, such as the university that I teach at, and that university hired this agency to provide supervision for their interns. And my university doesn't do this, but I'm guessing what is actually occurring here is that the university has a clinic, because if the interns were going into the community and working at regular agencies, the regular agencies have their own supervisors. So I'm guessing that this is a university clinic, and the university either is short-staffed or they don't have enough qualified supervisors as professors, or they just don't want to provide supervision for whatever reason. And so they've hired this agency to come into the clinic, which I'm guessing it's a clinic, to provide supervision. Okay, so you have that agency and the owner of that agency, and so moving forward. All right, the owner of the agency was a licensed professional clinical counselor, or LPCC. So the owner of the agency is not only the owner of a business, but also licensed as a counselor. All right, going on. The owner held the title of Director of Student Training, but I know from the rest of the brief that this owner does not actually provide supervision. In this role, the owner was responsible for the oversight of the intern training program, including policy implementation and intern assignments. This will all come into play later. All right. A second person at the agency is a supervisor and an employee of the agency, and this supervisor was responsible for direct intern supervision. I'm wording that kind of weird, but so essentially you have the owner, and then you have an employee of the agency that is hired as a supervisor to go to this university program and provide supervision for the intern. All right. So the client in this case was a 30-year-old female. She had a history of bipolar and a history of substance use disorder. She was under the care of a psychiatrist already. She had a recent hospitalization for treatment of a manic episode and psychosis. So just chiming in here. Hospitalization is pretty severe, but common for folks who are suffering from a manic episode, particularly if there's psychosis. What this can look like is that somebody is maybe hallucinating. They will have delusions, perhaps. They will be pretty confused about decision-making and about what's going on. They can become very grandiose about their own. They become extremely delusionally optimistic at times. They can be staying up all night. They have a ton of energy. They might be alienating everyone around them. There's just a lot of different profiles to what this can look like. But it's very concerning. From an outsider's point of view, it seems to come out of nowhere, particularly because the common state of someone with bipolar without treatment is depression. And then all of a sudden they seem to be in a good mood and you're thinking, oh, maybe they're doing better. And then they escalate to full mania, and it's usually short-lived, and usually given the behaviors and the signs, these individuals will very quickly cause so much concern from people around them that they might end up being hospitalized, either voluntarily, sometimes they'll go voluntarily, or involuntarily, either because the family convinces the authorities to do an assessment as to whether or not involuntary placement would be recommended, or the psychiatrist, or even the law enforcement will initiate this. Anyway, so we don't know the circumstances around that, but we know that this client had been recently hospitalized due to mania and psychosis. Upon discharge, the client was referred to counseling and instructed to follow up with her psychiatrist. So just chiming in here, what this indicates to me is that the client wasn't in counseling already. So upon discharge, the psychiatrist said, hey, you need to be in ongoing counseling. So that was the referral upon discharge. The hospital discharge summary noted that the client had been non-compliant with the prescribed antipsychotic medication recommendation. So just chiming in here, what the discharge summary is saying is that upon being recommended to take this medication to manage the client's mania or just bipolar in general, the client was not complying or was indicating that they weren't going to take the medications. And so that's pretty concerning, at the very least, because untreated bipolar can really ruin the client's life, but it can also be very harmful to others potentially. So right away, we're seeing some risks there. All right, going on. 3 weeks following discharge, the client contacted the agency to make an appointment. So, this is 3 weeks after. So it's a while after discharge. That's a little concerning right there. You would think that the client, if they were fully on board with the treatment regimen, they would contact a therapist that day upon being discharged. That would be the recommendation. But, we see 3 weeks. It's not a long, maybe there were some complications there, but it's just a little red flag. And it's possible that there's nothing in the brief that indicates either way, but it's possible that the client, given that they were non-adherent with the recommendations regarding meds, that they were begrudgingly going to counseling to begin with. It's just a factor to think about, that I don't know if that was present or not, but it has the profile of that. So 3 weeks following discharge, the client contacted the counseling agency to make an appointment. The client was assigned a new intern because the agency was short-staffed and there were no licensed counselors available. Okay, so just chiming in here, not only was it an intern, but it's a new intern. And that says a lot, because if you're an intern in your first term, in the first few months, that's different than if you're an intern close to graduation. You learn a lot. Typically an internship is about a year. So there's that. Now, some people might be thinking, an intern, that doesn't sound good. Well, you got to start somewhere. And interns, for the most part, if they are supervised closely enough, are capable and competent and able to treat all the same sorts of clients that everyone else can treat. And you got to learn somewhere. And often, like in this agency, you don't have a choice because you're short-staffed. There's no other slots available, so they've got to go to the interns. All right, so there's that. But you need to make sure you supervise sufficiently going on. The administrative assistant was in charge of assigning new clients to an intern. All right, just chiming in here. So the administrative assistant, it'd be probably someone that takes the phone calls or works at the front desk or something along those lines. And this admin person is in charge of assigning new clients. So when a new file comes in or a client calls or a referral comes, this admin's job, part of their job, was to find an open slot among the various, stable of therapists that are employees and assign that case to that particular therapist. And it's a pretty important job. And these admin people hopefully have at least some knowledge as to which clinicians are better than others given the situation at hand. Some admin people don't really know what they're doing, and they're just randomly assigning without considering a good fit, if you will. Some admin people don't have that luxury because of short staff issues and the amount of high-risk clients that come in. But that's what we're hearing. Other agencies will have supervisors that will do this or at least be a part of it, but it's not uncommon to have an admin person assign it. 2 weeks later, the initial assessment was conducted by the intern and the intern supervisor, and the client was diagnosed with unspecified schizophrenia spectrum and other psychotic disorder. All right, so let's scrutinize this part. So there's an appointment that's made, and then 2 weeks later is the initial assessment. It's not the best situation because we know that this is a pretty high-risk situation, given that the client was just hospitalized and is also potentially not compliant. Also, not only is the client apparently suffering from bipolar, but also is suffering from a substance use disorder, which can exponentially complicate things, not only for their own behavior and their medication compliance, but also risk of suicide, that kind of thing. Also, upon coming down from a manic episode, that can be a pretty high risk time because for these folks, they often, as they start to gain their sense of reality, they start reflecting back on what they did and how their life has been potentially severely negatively affected by their own behavior over the past few weeks. It can be a very stressful time, very sad time, demoralizing time. So it's very important that people get immediate help during and potentially monitoring during this time to get them through that time. So hearing that it's 2 weeks later, but again, not uncommon. And it's unclear if the admin assistant even knew, because the client calling the agency would have to inform about that. And there's no data either way, but I'm just going to take a guess and say that the client didn't say, hey, I'm in an emergency situation, I need a therapist right away. I'm guessing the client just said, yeah, I want a counselor. And sometimes that's all that's being asked about, maybe just like a tiny detail of the presenting problem. So anyway, we hear 2 weeks later, that's when the assessment is done by the intern, but the supervisor is there present in the assessment. So that's a good sign, because the intern alone, that'd be tough. But I would say 9 times out of 10, it is the intern by themselves. And with proper supervision and oversight, that isn't necessarily a problem. It's a common complaint or stress that I will hear from my interns that I am supervising, because I'll supervise them at the university side, and I will hear from them just how terrified they are. And often interns will be given, and I can't confirm this, but I think a lot of agencies will, say they get a new client and there's a lot of red flags that it's going to be very complicated and difficult. And when that admin person goes to the staff therapists that are more experienced, a lot of those staff therapists are already full, but also those staff therapists will say, I don't want that client. That sounds awful. And because the staff therapist has some political power, they can push back. And then the admin person is like, well, who do I give this case? Well, I'll give it to the intern because the intern doesn't know any better. And the interns are usually dying to get clients because they need their hours. And so it's something that I can't confirm that's what's actually happened. But I think it does happen sometimes. But again, with proper supervision, not only from the on-site supervisor, but supervision from me from the university side, we can help the therapist to get through it. All right, going on. Also, they diagnosed the client with unspecified schizophrenia spectrum and other psychotic disorder. I'm going to take a guess and say that in the time limitation that they had to assess this client, they either needed more time or the client was being resistant during the assessment. There's no data along those lines, but there just seems to be some profile indications of a client that isn't necessarily being fully on board with the treatment. Who knows? But a lot of times what clinicians will do is they will at first label someone with an unspecified, and then upon further assessment will lock in. If I saw this from an intern, I would say, that's a temporary diagnosis, correct? And they would say yes. Whereas if they said no, I'd say, that's not typically something that you'll land on. That's something that is unusual. It's unusual to have schizophrenia symptoms and psychosis, and you don't meet the full, or you don't meet enough of the criteria for schizophrenia or schizoaffective or bipolar. Anyway, going on. During the initial assessment, the client stated, just backing up. But what this does say is that the intern and the supervisor from the very beginning identified psychosis and some schizophrenia symptoms. So that says something. It says, well, they knew that something was going on there, and those kinds of symptoms carry with them a fair amount of risk that would raise your intensity level regarding the need to monitor the situation and to make sure that the client is doing okay, particularly in the initial phase of therapy, because you don't really know the rhythms of the client yet. All right, going on. During the initial assessment, the client stated that she had suicidal thoughts in the past, but she currently denied having a plan or a means or an intent to kill herself. The client also denied having any recent suicidal ideation. All right, so just chiming in here. The brief is very brief, if you will. And if you're a clinician, you might know, but you might be reading between the lines, but for you non-clinicians, so this initial assessment is conducted. I'm going to take a guess and say it could have been even just an hour long. A lot of assessments, that's all the time they have. Could have been a couple hours, but I'm going to take a guess and say that if the supervisor was there, tops would have been 90 minutes. So it's hard to get a lot of information during that time. But anyway, they, as a part of the assessment, either asked or the client volunteered that the client had, in the distant past, had thought about suicide. There's no mention of it here, but I'm guessing the implication is that the client did not indicate that they had ever attempted. So that was my question as to the hospitalization regarding mania. A lot of hospitalization, mental health related, have to do with suicidal risk. But with mania, that's not typically the case. Anyway, it's just a detail there. But the client stated that she had in the past had thought about suicide, but she denies. She currently says, I don't have a plan. I don't have the means to kill myself, and I don't have the intent to kill myself. And I haven't even recently thought about suicide. Okay. Now, with bipolar and potentially with schizophrenia spectrum and psychosis, you should know that could change pretty quickly. Other kinds of clients, for example, if someone suffered from moderate depression, you assess that in the first session, and they say, let's say they're 35, and they say, yeah, I used to think about suicide when I was a teenager in my early 20s, but I haven't, that doesn't occur to me anymore because of this, and this, but I am very depressed. If you heard that's a more stable possibility. You still need to do everything you need to do to protect the client and to address it. But when you hear schizophrenia spectrum with psychosis, particularly with the recent hospitalization, which they don't know about, which they never find out about, by the way, then at the very least, we know, because of the information that we have available to us, that just because she's currently saying she does not think about suicide does not mean that it couldn't change on a dime at any point. Like another profile, if I had a client who was suffering from grief because of a divorce or something, and when in the course of assessment I asked them if they'd ever thought about suicide, and they said no, they've never thought of it. It's never occurred to them. They've never considered it. That it's just never, no matter how bad life gets, they would never do that. That's a very different situation. I'm not going to think that next week suddenly they're going to start thinking about suicide. That would be very rare. It could happen, and I need to monitor things, but that would not be a prediction. Whereas with bipolar, schizophrenia, psychosis, recent hospitalization, the information we know, substance use disorder, it's not a severe risk at this point because the client is reporting anyway that they aren't thinking about it and they don't have a plan to do it. So it's not a huge risk in the upcoming weeks, but it's more of a risk because of that. Also, given everything that we know, the fact that she was not compliant with a medication is another red flag. That would, if I were the supervisor in this case and I knew all the information, I would be telling the intern, you have to, in the beginning anyway, treat this case as if it were just baseline a moderate risk of suicide, even though there's no signs of it, because there are these other factors. And so, let's just make sure that we're keeping track of that and addressing that, maybe even having a safety plan. And a safety plan would be good anyway, not just for suicide, but given everything we know, a safety plan regarding if the client were to escalate in terms of her mania. If you see the first signs of mania, here's the crisis plan. Here's the plan that we're going to implement and that you're agreeing to implement. Anyway, so just going on. The client reported that she was under the care of a psychiatrist, and she did. Now, some of you might be thinking, isn't there just some database that the counselor and supervisor, the intern supervisor, could just look at? And maybe there is. I'm not aware of one. We need the clients to tell us stuff. So going on, the client told the intern and supervisor that she currently had a psychiatrist, but she did not inform them that she had recently been hospitalized. And the supervisor and the intern did not inquire about hospitalizations. So the fact that the intern and the supervisor didn't know and never found out about the hospitalization, is that because they didn't ask? Or is that because the client was withholding that? We'll never know, but of course they should have asked. And it's one of those standard questions that you ask, particularly if you're detecting schizophrenia symptoms and psychosis. Like that should be the immediate question. So have you been hospitalized at any point? Now, it's hard to, you can't really blame a client in this situation, but if I were a little birdie on the client's shoulder, I would say, tell them that you were hospitalized, even though they're not asking you, that's relevant. All right, going on here. A consent form was signed by the client, meaning that the intern and supervisor said, hey, can we talk with the psychiatrist? Yes. Okay, well, you need to sign this consent form. A consent form was signed by the client permitting the supervisor to request the healthcare information record from the treating psychiatrist. The record request was sent to the psychiatry office. However, due to an administrative error, the records were not received
by the agency, and neither the intern nor the supervisor followed up to ensure receipt of the records. It wouldn't be unusual for an intern and a supervisor to have collectively like hundreds of clients that they're treating, and you can't be expected to keep track of all the little details. And you're running around client to client, and then you sit down. When I did this kind of work full time, a client would walk into my office at the agency, and I'd be like, "Oh, it's that client." I wouldn't even know which client because I was just so frazzled all the time. And then they'd sit down in my office, and I would not have thought about them since they left my office. So, it was just very stressful and overworked and that kind of thing. So you need to have reminders to look at when you're calm and have the time, be like, oh yeah, that's right. I need to make sure that I reach out to that psychiatrist. And they didn't do that. And part of the problem is that this kind of labor, the labor involved in tracking these records down, we are often not paid for it, and we can't necessarily bill for it. And thus, there's not a lot of yelling at us to make sure that we do it. And there's not a lot of attention given to these kinds of things. And we call this like collateral contact. And I've seen a lot of clinicians neglect this area, unfortunately. All right, so let's take a break. We get back, I'll continue. All right, we're back from the break. Another thing along these lines of what I was saying earlier is that the psychiatrist also could have done better by reaching out to the intern and the supervisor after getting the consent form. So if you're the psychiatrist, you aren't necessarily monitoring the situation closely, but hopefully you're concerned about this client. And so when you receive this release of information, you're like, oh, okay, good. My client that was recently hospitalized is connected with a counselor now. That's great. And they're requesting the health record. Okay, I'm going to send over the written record. And, it's pretty limited, the written record. So I am going, as a psychiatrist, I should, one, make sure they received that, and two, just have a conversation for 10 minutes over the phone to let them know the highlights and to just connect so that we can confer. A lot of times with collateral contacts, for me, the initial conversation is just an introduction. It's just a, hey, I've got your number. I now know the best way to contact you. What's the best email for you? That kind of stuff. And then having that already established, it makes both of us a lot more likely to reach out to each other when there are concerns. Whereas if you just don't have that introduction, sometimes it just feels like a hassle in the moment and people will avoid it. Anyway, going on with the brief. All right. So 2 days following the initial assessment, the client initiated counseling with the intern. All right. So that's good right there, is that it took 3 weeks for the client to call the agency. It took another 2 weeks to find a time for the assessment. But 2 days following the initial assessment, the client is in session with the intern. So pretty quick turnaround. That tells me the intern had a lot of space in her schedule going on here. And the client continued to participate in weekly counseling sessions over the course of a 2-month period. During these sessions, the intern utilized techniques such as rapport building, active listening. The intern incorporated the client's passion for music into the counseling techniques. These techniques enabled the client to communicate her emotions through the use of lyrics. So just chiming in, this all sounds great. Building rapport, active listening. The intern is entering the client's world of music and lyrics, and the client is finding it easier to communicate about things through lyrics, maybe songs that she had written or something. So things are looking, good in that area. Approximately 2 weeks after the initial counseling session, The supervisor reviewed the intern's progress notes. So I'm guessing this is 2 sessions of reviewing that the supervisor is doing. The supervisor identified that the intern was not performing suicide risk assessments. The supervisor emailed the intern and advised that a suicide risk assessment should be performed at each session based on the client's prior history of bipolar. All right, so when I get to this point in the brief, I'm thinking, so they do know that there's a history of bipolar? The only way they would, since they never got the records from the psychiatrist, would be from the client. So what I'm hearing is the client told the intern and the supervisor, I have a history of bipolar. So that's what it says to me. But anyway, going on. The supervisor also communicated detailed instructions about how to assess suicidality. Based on the feedback received from the supervisor, the intern conducted suicide risk assessments at each future counseling session and noted that the client denied suicidal ideation. All right, so just summarizing this. The supervisor reviewed the record, didn't have a conversation with the intern, just reviewed the progress notes, and noted that the intern was not conducting a suicide assessment. Now, under normal circumstances, if someone had a distant history of suicidal thoughts, but didn't have any recent suicidal thoughts and had never attempted, it wouldn't be, in my book, a necessity to ask every single session. But given the bipolar, that's when the supervisor says, well, regardless, you still need to be assessing. So that was a good indication there. But we're hearing the way that the supervision is being done. We're hearing email, reading of progress notes, that kind of thing. Because typically, the way supervision is conducted is in-person, one-on-one meetings, where, particularly for interns, but really at any level, every supervisee I've worked with, I meet with them one-on-one for an hour, and we talk about their cases and their development, and we talk about deficits in their, the supervisee's learning, and we talk about technique and personal development, self-awareness and countertransference, and career, and their personal life stresses that might affect them, and also their work with clients, blah, blah, blah. So we're hearing email and reading of progress notes. All right. And then the supervisor, in a good move, says, no suicide risk assessment. You need to do that. And the intern said, okay, I'll do that. And the intern started to do that every session. All right. The standard of care is that, so I'm back to reading. The standard of care is that supervisors meet regularly with supervisees to monitor their work. Again, like I said, once a week. But usually what I see, the interns that I work with, they have a one-on-one supervision meeting with their on-site supervisor. So I'm at the university, and I have a class that's 3 hours a week, and the class is usually around 6 students, sometimes less, and we talk as a group about their cases and development as a therapist. And the intern in my class also, because they intern at a site like an agency, and that agency has a supervisor that's supervising them as well. And the supervisee is getting group supervision on site as well. So the intern both meets one-on-one with their supervisor, and the supervisor will hold group supervision for all of the interns or a group of the interns at that site. So the intern is getting 2 hours of supervision at the site, and they're getting 3 hours of supervision a week from me. So that's 5 hours. Now, at the very least, you should get at least 1 hour of supervision every week. But like I said, 2 hours is better. Really, especially in the beginning, the intern needs a number of hours. And what I will say is, in the work that I do, when my interns are getting 5 hours of supervision a week, and then sometimes I'll meet with them outside of class, which would be another portion of time. Those 5 hours, it's still not enough because these interns, they've learned a lot up until that point before they started their internship, but there's just so much to learn. And it's one thing to read about it in a book. It's another thing to do it. So they're saying, the standard of care is that supervisors meet regularly with supervisees to monitor their work. They don't lay out exactly what that means, but to me, it means at least once a week, if not much more. However, the supervisor conducted all supervisory communications with the intern via email, and there were no regularly scheduled supervisory meetings. So just chiming in here. All right. So all of the supervision was conducted over email. That is, there are a lot of things you can do over email. You could schedule an appointment. You could send a happy birthday. You could coordinate a party or something. You cannot provide supervision over email. It's just, some details of supervision, maybe, but you're never going to be able to supervise someone even remotely sufficiently over email. It's just not possible. So we're hearing that, yikes, going on. The agency owner did not establish or implement formal policies delineating supervisory requirements. The owner also did not institute a process of handling client emergency site situations. All right, so just chiming in here. So the owner is responsible for the policies of the agency that the supervisor works at. It could be argued, and who knows what the situation was. It's possible that the supervisor was asking the owner, hey, I need more time. You need to, because it's money is the problem, is that in order to provide the interns that I work with 5 hours of supervision, well, all of those hours of supervision has to be paid for by somebody, right? And time is money. So when you're profit oriented or concerned about money, the bottom line, sometimes one of the corners that will be cut will be supervision time. It should never be cut, but it's one of those considerations. The reason I was saying that 5 hours isn't enough, I would say like in a perfect world, and sometimes interns will have this, is you have those 5 hours that I laid out, but they also have the ability to, in the moment or very quickly, access one of their supervisors, whether it's me or their on-site supervisor, to just ask small questions and big questions. Like they just got out of session and they don't have supervision for another few days. They can call or bop into their supervisor's office and ask them a question. Some interns will have that, but usually they don't. So to allow for that, you have to have the supervisor just sitting there doing nothing, and that's money. And the supervisor could be doing something else. They could be treating their own clients, and that generates revenue. Supervision generally doesn't generate any revenue, right? It's complicated. But point is that the owner might have been telling the supervisor, you need to limit your time because you have to do all these other tasks. You have to limit your supervision time of this intern. And the supervisor in all likelihood had a number of other interns as well. So who knows? But I don't know who to blame. Now, I will say that for me as a supervisor, I have been in that, normally as a supervisor, the majority of my supervision was done in two venues. One is that I was at the university and I would have a small group of interns that I would meet with for 3 hours a week, and it would be group supervision that I would just occasionally do in a one-on-one supervision with all of them. That was one venue. The other venue was I would supervise post-grad therapists, people who had graduated, and to get your license, you need to have a certain number of hours of client time and a certain number of hours of supervision time. So people would hire me to meet that requirement. Also, I think also to hire me just because they wanted further help regarding their clinical work, right? And so I would be providing that service to them. But occasionally, agencies would hire me to provide supervision for their staff therapists and or their interns. And there have been times when these organizations hiring me will not give me enough time and space to adequately, even at a minimum level, provide supervision for those clinicians. And at first, I'll try to make it work. But if I feel like, there's two considerations that I have in the situations. One is that what if a client is harmed, and or what if a clinician, what if one of my supervisees is left out on the lurch and I didn't have enough time to help them. But two, what if I get sued? Because if I don't have enough time to monitor and assist and guide these supervisees, then stuff's going to start falling through the cracks. A client is going to get harmed. The family or the client's going to sue the therapist, and then I'm going to get dragged into it because I'm the supervisor and I should have been doing something, And I don't want that to happen. I don't want either one to happen. I don't want a client to be harmed. I don't want one of my supervisees to be harmed, and I don't want to get harmed. So what I will do is and really it's just a matter of principle, is I will go to the powers that be and I'll say, either you allocate more funds and time for me to adequately supervise, or I quit. And I've had to push back sometimes. And there's a lot of other stories I could tell you, not only just in that role, but in other kinds of roles. We don't know. We don't know if the supervisor wanted more time and wasn't given it. We don't know if the supervisor was allowed more time but just didn't use it. But we're hearing that the supervisor is doing all of their supervision over email, which is just completely unacceptable. We're also hearing that the owner had no established formal policy about how much supervision needs to occur, which typically would be the case. You would have a policy that says you must meet one-on-one. A lot of times agencies, they don't want to be sued. And they also they do want to provide a good service to their clients, at the very least out of altruism. And at another level, a matter of marketing, right? You don't want a bad Yelp review, and part of it has to do with oversight of your workers. And so agencies usually are in the business of telling interns, look, you have to meet with your supervisor every week. Because sometimes an intern will cancel a supervision meeting because they're busy or whatever, and then the agency will crack down on the intern and say, no, you can't. You got to reschedule it the next day because you need to. So there's a lot of different attitudes about this, and what we're hearing about this agency owner is there was no policy. It was just like up in the air, and it was unofficial or hadn't been thought about or something. Maybe it was a new business. I don't know. The other detail here, which will come into play later, is the owner had no policy about how to handle client emergencies, which is just amateur hour. That should be the first thing that you have available to. Also, you don't have to invent the wheel or reinvent the wheel. Crisis emergency policy and plans are well established. You could probably just Google it and find a dozen examples and then just maybe modify it slightly or just use that, because it's not, you don't have to think about it much. You could just say, it wouldn't take long is the point. The problem, and I don't know, is that requires time and energy. And if you're trying to cut corners, you might cut that corner. All right, going on. The day before the 10th counseling appointment, the intern received several texts and voicemails from the client containing pressured speech with erratic and disorganized thought patterns in a lyrical format. All right, so just chiming in here. Sounds like mania, right? And remember her history of mania, but also her history of noncompliance with medication. We don't know. It wasn't told to us in the brief, but it's quite possible that she never took the medication upon discharge. It's unclear. If she was suffering from a substance use disorder, given the fact that she hasn't received any sort of substance use treatment, in all likelihood she was still using whatever she was using. But anyway, so the day before the 10th counseling appointment, the intern receives a bunch of texts and voicemails from the client that are disorganized, erratic, and are communicated in a lyrical format in reference to the content of the sessions that the therapist and client had established. So pressured speech. Okay, sounds like mania is occurring. So the intern, upon getting this, was concerned, and the intern shared the texts and voicemails with the supervisor. So intern, 2 thumbs up. That's great. It sounds like an obvious thing to do, but I've had interns and supervisees that never did this. And then a couple weeks later, they'll tell me, oh yeah, this thing happened. To be like, remember our talk about informing me? 99% of the supervisees that I've worked with are on the ball, responsible, lovely individuals, but, occasionally. So this intern immediately contact supervisor, inform them, giving the supervisor all the information they need to act appropriately. Going on, the supervisor advised the intern that she could address these communications at the next scheduled appointment and that no immediate action was necessary. All right. So given that this is a brief from my malpractice insurance, we'll assume that this, and I've already read ahead, we'll assume that this story doesn't end well. But the vast majority of situations, if you're faced as a supervisor, if you face 100 of these situations, 99 of them will not result in anything bad happening. So just think about what the supervisor knows at this point. Well, one, they've had zero communication with the psychiatrist. They don't know about the hospitalization, but they presumably would have found out about it if they actually had that communication with the psychiatrist. So the supervisor doesn't know anything, probably only knows what the client said, which I'm guessing was, I have bipolar and I have a psychiatrist and I have medications or something. And the supervisor also knows from the client that the client reports no current or recent suicidal thoughts. Okay, and no means, no plan. I'm assuming no previous attempt, because a previous attempt is a huge risk factor in a future attempt, according to research. So the supervisor doesn't have any reason to believe that suicide is imminent. And these texts and voicemails don't indicate any kind of suicidal thoughts. It's just garbled, psychotic, pressured speech, right? Now, you're hearing what sounds to be like a client that is in full mania, possibly psychotic. That carries with it a certain amount of risk, right? And I wouldn't, if I were the supervisor, I wouldn't say, the way that the supervisor reacted is something that we will do as clinicians and as supervisors often. Not in this situation, but it's not uncommon, particularly given that most clients can communicate to their therapist via email or text. It's not uncommon for a client to occasionally or frequently have, disclose something or inform the therapist about what's going on with them outside of therapy. Like a client. I'm just trying to think. Okay, so let's say you're treating a client and it's been 6 months, and then I'm the therapist. I'm treating this client, and then in between sessions, I get this email, and it's very long, and it starts out by saying, "Hey, my husband left me suddenly, and I don't know what's happening. Is he cheating on me? And it's just a lot of thoughts, right? And if there's no reason to believe there's an emergency or any kind of risk or red flag, then a common response from me as a matter of policy, because it's written, in my disclosure, is I will reply back, and I'll be brief. I'll say something to the effect of, I appreciate what you're going through. I'm so sorry this is happening. We will definitely get into this in our next session. And when the client comes to the next session, I might say, would you like me to read the email out loud now? Would you like to read it? Or do you just want to or you just want to tell me what happened verbally. The reason why I do this is because I have learned that if I, as a policy, entertain those kinds of emails, then with a very small minority of clients, it's very rare that this would happen, but with those clients, they will email frequently, maybe even every day, and they'll be very long. If for example, with certain clients, if I were to reply in a very lengthy way, they might reply back in a lengthy way. And so, and I'm not saying that's bad, it just means you have to consider that possibility as a therapist when you have these kind of policies. So unless there's an emergency, and sometimes with some clients, if it's particularly long and I'm particularly busy, I might even reply back. I might even say, "I'm sorry, I'm super busy with work. I only had time to read the first 3 sentences, so I didn't have any time to read the rest. If you are in an emergency, you need to call 911 or follow the safety plan, or email back to me with like a 1 sentence. Is there a request in here? Just some kind of cut to the chase, please, kind of a thing." And of course, this all has to be considered within the capacity of the relationship to handle this kind of blow. And of course, I've learned over time that I need to inform people in the beginning of therapy along these lines. I'll tell them right up front. I'll say, like, my policy is this about emails and texts, and so if this happens, this is what I'm going to do. Just so that if it does happen, I'll be able to remember when I talked about that and anyway. So it's not unusual as me as a supervisor to tell an intern, a supervisee, okay, because the supervisee often they don't know what their policy is yet, or they're worried about crises, naturally, but they don't know how to detect what a real crisis is. So they'll reach out to me like, "Oh my God, I got these emails," and I'll look it over, and sometimes I'll just say, "Well, I don't see any reason to worry about a safety concern." So what my recommendation is that you want to draw a bit of a boundary here, not because you want to be a dick, but just because you can't. Once you open that door, it might open the floodgates to an expectation that you are basically available 24/7, and that's not good for you. It's potentially not good for the client as well. So you want to reply back with empathy and say you'll definitely talk about it in the next scheduled session. So that it sounds like that's what they did. That's what the supervisor did. But given even what the supervisor knows, but also the supervisor should have a question mark here of, we don't know what the psychiatrist would say. We only know information from the client. What if the psychiatrist would tell us that this person is in grave danger of something? We just don't even know. So we need to play it safe by addressing this more rigorously. And as a supervisor, upon looking at the record, they should be kicking themselves for letting 10 weeks go by without having confirmed communication with the psychiatrist. But but anyway, so if we just enter the mind of the supervisor, well, I'm guessing this, if we assume the supervisor doesn't consider supervision to be as important as they should, and evidence of that is doing supervision over email, and if we consider that, then the supervisor is probably fairly hands-off and doesn't have the fear of God in them, so to speak. They don't worry about danger or risk or being sued or something. So it wasn't motivating them, and they're just like, okay, well, what do I know? Well, we know that the client has indicated no indication of suicidal thoughts. So, and there's no new, and the intern has been assessing that every session. So there's that. We know the client has a history of and current symptoms of schizophrenia and psychosis, and hopefully the supervisor immediately recognized a strong possibility of mania. And it's just strange that under any circumstance, if if I had an intern that presented me information that their client was in the midst of a spike in mania, I would one. So then we have to talk about safety planning. In the very first session, the assessment, presumably the client tells the intern and the supervisor that she has a history of bipolar, because we hear that in the brief later. And they did diagnose with this unspecified schizophrenia with psychosis. So right off the bat, either session 1 or session 2, definitely by the end of session 2, a safety plan should be established about symptom management and about safety management. That, okay, if these symptoms start to occur, this is what you will do. You will call your psychiatrist. You will call us. You will engage with your support system. You will go to the hospital. You will call 911. There would be a safety plan. Safety plans aren't just for suicide. They're also for homicidal ideation, but they're also for these kinds of situations. Because as a clinician, the chance that you're going to be in session as these things are happening is very slim. The things are going to happen outside of session, and you're responsible for doing what you can to reduce harm outside of the session as well. And so when you hear these symptoms, a safety plan should have been established, but we don't hear that. Because when I think about what the supervisor should have done in this moment, if they don't have a safety plan, there's not a lot the supervisor can do. The supervisor could tell the intern, okay, you're getting these texts and voicemails, intern of mine, you need to schedule an emergency appointment with this client. Well, given the client is so disorganized, what's the likelihood that the client is even going to be able to make an appointment and, establish one and actually show up for it? So it's hard to corral a situation that you didn't do any prep for. Anyway, going on. Based upon this advice, the intern told the client that they would discuss any new issues at their upcoming counseling appointment in 2 days. Notably, the intern later testified that she was not aware of the association between pressured speech patterns and manic episodes. All right, so just chiming here. So later, because this goes downhill, the intern testified that hey, I didn't know what I was seeing. I now know we call that pressured speech. I also now know that that's associated with mania. I didn't know that at the time. Now, for some people reading that or hearing about that, they might think, wait, so you have a clinician that doesn't know that pressured speech is a symptom of mania? Particularly when the client presented with a history, stating that they have a history of bipolar, presumably, and also showing signs of psychosis and schizophrenia. You didn't know that pressured speech is a component of mania? Okay. So on one hand, yes, that isn't great, but it's not uncommon. That's why, especially new interns, need very close oversight. The intern might have learned it, but forgot it. There's a lot of information that students are trying to retain, and some of it's going to go. Also, learning occurs with repetition, particularly when you're finally in front of clients and you're not just reading about it in a book or watching an actor in a vignette DVD or whatever. They probably don't use DVDs anymore, but anyway. So the intern didn't know that, and but the supervisor saw the emails or saw the texts and listened to the voicemails. Surely the supervisor should have known. Anyway, going on. Later that evening, the intern received an email from the client's boyfriend. So this is just later that day. So earlier in the day, texts and voicemails, pressured speech, lyrics, Supervisor, the intern reaches out to supervisor. Supervisor says, just wait till your next session. It's in a couple days. Later that evening, the intern receives an email from the client's boyfriend. He stated that the client was exhibiting manic behavior. Use the word manic. He also stated that he was concerned for her safety. All right, so just chiming in here. I know from the later in the brief that the boyfriend and the therapist, the intern, had never communicated before. So this is out of the blue. And what I'll tell you is, from my personal experience and also upon reading a lot of these briefs, is that this is a huge red flag that needs to be paid very close attention to. I mean, there's already been red flags, but when you have a family member that reaches out to you out of the blue and says, I'm worried about my person in my life, such that I'm actually contacting, I figured out how to contact their therapist, and I'm telling you something's going on here. Because people almost, there's a high bar for people to do something like that. So if someone's going to do something like that, then that is a sure indication that the risk is a lot higher than otherwise. Also, just from a liability standpoint, if you have a family member that is reaching out to you and you drop the ball, then the family member is like, my God, I called you and told you, and you did nothing, or you didn't do enough. So, it's just something to think about. First priority is the moral responsibility that we have to humans, such as our clients. But, secondarily is the concern of just your own skin as a clinician going on. The client's boyfriend also said that he did not believe that the client knew who to contact. The client's boyfriend also said that he didn't believe that the client knew who to contact in an emergency. He said that he had to search through the client's computer to find the intern's email address. So just chiming in here. So the boyfriend is saying, I don't know if my girlfriend even knows what she's supposed to do if she is having an emergency. So what that tells us is more information in the direction that there was no safety plan, no discussion of what to do in a crisis. And this really just drives me nuts. And also, the safety plan should have involved the boyfriend from the beginning. That's what I do almost all the time. And if I'm not doing it, it's because there is no one in the client's life, or the client is refusing, maybe for good reasons, that they don't want their partner or their family member or one of their parents involved. But I find the single most important thing that can help me sleep at night with certain clients is if I have a family member involved in the safety monitoring and implementation. So I do everything I can to try to convince the client, if they're resistant to, involving someone in their life, because that person's there 24/7 in a way that I can't be. Anyway, also, as a secondary thing, just as a save your own ass kind of a thing, is that if the family is involved in the monitoring and they know as much information as you do relevant to the safety concern, then if something bad does happen, like suicide, then the family they probably won't blame you, because you were communicative with them and you were letting them know and giving them the tools and giving them recommendations about what to do under such circumstances. So if something bad happens, they're not going to think that you dropped the ball, because they have a lot of evidence showing that you were doing everything you could. Anyway, going on. Shortly after reading this email, the intern was noted. Okay, so you have earlier in the day, the lyrics, the voicemails, the texts. Intern reaches out to supervisor. Then the boyfriend calls, and the intern's like, huh? Now, we don't know what the intern was thinking at that point, but shortly after reading this email from the boyfriend, the intern was notified by the client's family that the client had died by suicide. So that's what happens. And I'm only laughing because I'm uncomfortable, but it's awful. It's awful. It's awful. It's awful. If I'm going to take a guess, I'm going to say that you had a woman who was developing bipolar throughout her 30s, had shown signs. This is a pretty typical course of bipolar. Maybe late teens, early 20s. There's a little bit of depression, a little bit of mania, It gets worse over time. She turns 30 and the symptoms become much more severe, much more noticeable. She ends up in the hospital and she's new to treatment and medication, or relatively new, and is kind of reeling from the whole experience and is maybe even takes the medication, the antipsychotic medication, and doesn't like the side effects. They often do carry with them some very unpleasant side effects. And so the client's like, oh, no, I can handle this. I don't need the medication, or I don't need therapy. I just need to get my life in order or something. And then, she complies by getting a counselor. Who knows what she was doing with the medication. And she did not know that it was going to happen again, and then it happened again, and then who knows what sort of step by step resulted in her killing herself. You could argue that the intern should have done more than just listen and build rapport, that the intern should have been advised to talk with the client about adherence and compliance, and also the risks. So that's what I've done. Whenever I have a client, like particular, and I don't know where, maybe this client with bipolar had been diagnosed 10 years prior, but that wouldn't be normal. The way it sounds like it's a relatively new. It could have been brand new, or it could have been a year old or something like that. It's pretty common for people in the beginning of their diagnosis of bipolar to resist accepting it. And so then she died by suicide. If she had proper treatment, there's a good chance they would have been able to get her through this difficult time, and she could have emerged on the other side of this initial phase of treatment with an acceptance of the diagnosis and an adherence to the treatment regimen. A grieving process is often involved, and the acceptance that you have this ongoing severe mental condition, and you're just going to have to live with the side effects of the medications for the rest of your life, and the worry, and also the fallout from the episodes that you've had. And there's a lot involved. It's very difficult, but with proper treatment, with enough attention, it's quite possible they could have gotten her through it. It's also possible that no matter what they did, the intern and the supervisor, that she still would have died by suicide. We just don't know. Of course, I'm going to assume that the intern was devastated by. I've been close to situations like this, and it's not uncommon for an intern in a situation like this to consider and even take action to quit their career as a clinician because of this. I had a supervisee once early in my career who had a stressful situation on the job, and she quit as she just, she was almost to graduation, and she's like, yeah, I can't handle this. I'll tell you specifically what happened was we were doing group therapy with teenagers in the agency, and it was a house that was converted into an agency. And so we're in the back of the house, and there was a back door, and a random teenage boy walks in through the back door and identifies one of the girls in the group, their boyfriend, girlfriend, and then the girlfriend is like, oh, and they leave together. The boyfriend's like, hey, I don't know, I'm trying to remember this was literally 25 years ago, but I think the boyfriend was just like, hey, you're no longer under the thumb of your parents. They're not around right now. How about we use this opportunity to skip out and get some time together or something? And the girlfriend's like, yay, let's do that. So she leaves. And I'm in the beginning of my career, but I don't know, situations like that just don't really rattle me. But my co-therapist was an intern that I was supervising in that capacity. And, I immediately called the intern is looking at me like, well, what do we do? And I'm like, you don't have to do anything. You're the intern. This is my job. So, observe, I guess. So I called the police and I called the parents, And I gave a description to the police about the situation, and then we continued to monitor it. The parents would give us updates that they hadn't seen her, and it was several hours later, and we still hadn't, the girl hadn't shown up yet. And I'm thinking, well, they're probably just smoking weed and making out in a car or something. It's the most likely situation. It's not great, but what am I supposed to do? I can't chase her or tackle her or chain her to her chair or search the neighborhood for her. I'm limited in what I can do. So if something bad happens, I don't think this could possibly be my fault. I'm worried about this teenager, but I'll use that worry to motivate me to document well, consult with a colleague, but then that's the end of the line in terms of the options. The intern, she was very stressed out about it. She was stressed out about it overnight. I think we might have talked about it later that evening after our shift, maybe the next day or something. And she's like, "What? I don't understand. Like, what are we supposed to do?" And in the end, everything was fine. I don't know what the teenager girl was doing, but from my memory, it was something like that. It was like, well, let's just assume they were. She showed up the next day or something, and she was probably just making out with the guy or something. I don't know. And the intern, it was a long time ago, but she eventually told me that experience was so stressful to her that she realized that she could not be a clinician, and she dropped out. So, this could be, and that's that situation. Imagine what this intern went through. A new intern, maybe in the first couple months of their career, and they have a client that dies, and it's possible that the intern is partly to blame, that they didn't do enough, right? The supervisor, I'm going to take a guess, is also besides themselves. People get into this career not because they're just trying to pass the time. They're trying to help people, and to have a suicide happen, and it's possible that you didn't do enough to address it. It's devastating. Even when you did everything you could, it's still devastating. You're still in it blaming yourself. So I'm going to take a guess that's rough. And then the owner of the agency is also a therapist. I'm going to assume that individual also cared and is very saddened by this. Maybe a lot of self-blame, some that is justified, some that's not. I don't know. But this is awful. And then if you're the boyfriend, if you're the family, and you're thinking, we thought our family member was under good care. And then when they find out the details, they're like, what? It's very, very upsetting situation all around. Okay. So going on, several months after the client's death, the client's parents filed a wrongful death lawsuit asserting that the intern, the supervisor, and the agency owner failed to provide appropriate treatment. The treating psychiatrist who worked at the previous agency or at the hospital was also named as a defendant in the lawsuit for failing to ensure that the client adhered to the medication regimen. So we haven't heard much about this side of the lawsuit because the psychiatrist, I'm guessing, has a different malpractice insurance, and therefore this brief doesn't have access to information or whatever, but just know that the psychiatrist was also sued by the family saying you didn't do enough to make sure that she was actually taking the medication. Now, some of you might be thinking, well, what are we supposed to do? We don't have the power to force people to do things. And that is true. But we are responsible for taking reasonable actions within our capabilities to increase the likelihood of safety behaviors occurring. So if you're a psychiatrist, you can't force someone to take the medication under most circumstances. But what you can do, if you're the psychiatrist, is check in with the client more often. There's no evidence either way. I'm guessing the psychiatrist didn't do that. You could have also made sure that the agency, the intern, had the information. You sent the file over, but you never had confirmation that they had received it. Plus, you didn't call them to have a conversation over the phone. As a psychiatrist, you might even consider it your job to make sure that the intern is doing the right thing, even though you're not directly a supervisor, but you're a senior clinician and you're involved with the client. I mean, I've been that way. I've had clients who have psychiatrists who I felt were in over their head, and I would reach out to those psychiatrists. I'm not their supervisor, but I'd reach out to those psychiatrists and help them to get through and understand and get more aligned with what I believe to be the treatment path. So, I mean, that's asking a lot, but at the very least, the psychiatrist could have done more, could have had more check-ins, more, in-person check-ins to just make sure that Medicaid, they could have lobbied for additional hospitalization because of the lack of adherence. Anyway, going on. The plaintiffs further asserted, so the family, they further asserted that the agency owner was negligent in failing to implement policies regarding supervision. So I've already been over this, but yeah, clearly. So going on, the plaintiffs' counseling experts, so the family and the lawyers, they hire experts to look over the case, to provide insight and guidance, but also potentially to testify in court if need be. And these experts looked into it and they said, yeah, the agency should have had policies about supervision, and they didn't. And yes, the agency should have had policies about after-hours client emergencies. The experts are thinking, how do you possibly not have a policy about after-hours emergencies? What's wrong with you? They also said that an intern should not have been assigned to this client, or if the intern was assigned to this client, the supervisor should have been much closer of a supervisor to the situation. Now, to their credit, in response, the agency owner and the supervisor said that if they had known about the client's recent psychiatric hospitalization, the client would have been assigned not to an intern and to a licensed counselor. So the agency owner and the supervisor are saying, well, with the information available to us, we have a client with no prior attempts, with a history of suicidal thoughts, which is very common, by the way, but no current suicidal thoughts. We didn't, there's no sign there of risk. But given that there was this hospitalization that we didn't know about, that would have caused us to take more action. Now, the other thing here is, okay, you didn't know that, and that's mostly due to your negligence, because you didn't make sure that you had open line of communication with the psychiatrist. Going on, the experts for the family also said that there should have been an immediate client intervention when the intern reported the client's change in condition to the supervisor. So when the intern contacts the supervisor that day and says, hey, I got these emails and voicemail, and the experts are saying there should have been an immediate response. The supervisor either should have done it themselves, or the supervisor should have told the intern, you need to reach out to this client right away, blah, 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 or whatever. And that wasn't done. Now, I'm going to take a guess and say that even if that had happened, that the client still would have died by suicide. Because if we look at the timeline here, we have, at some point during the day, the intern receives these texts and these voicemails. The intern shouldn't be expected to respond on their own to that. It takes time to reach out to the supervisor. It takes time for the supervisor to have a free moment in their day, because they're doing their own appointments, right? They get that information. It takes time to communicate back. By the time that communication happens, and by the time the intern or the supervisor does anything, I'm just going to take a guess and say that it's pretty low likelihood, because the client died by suicide that evening, that day. Now, that's not necessarily relevant earlier when I was saying you could have the same outcome, but different actions that lead up to that outcome, and one will be considered unethical and a problem, the other one will not. In this situation, we see a lot of neglect and a lot of mismanagement and a lot of bad choices. So it's not a matter of whether or not we predict that something could have been done. The fact is that if something could have been done, those things were not done. And so, there's a chance, and if everything was done properly from the beginning, then there's a pretty good chance that the client wouldn't have been suicidal that day or manic to begin with because of the collaboration with the psychiatrist and the because one of the things that could have happened if they were paying, better attention, not extreme attention, just normal attention, is the intern and supervisor would have told the psychiatrist, look, we can't confirm if this client is actually taking the meds, so you're going to have to, do more. And so the psychiatrist, okay. So the psychiatrist starts to do more. And then eventually 5 weeks in, the team starts to talk with the client, getting the boyfriend involved maybe and other people. And they say, hey, if you aren't taking your medication, then we are going to move towards involuntary hospitalization again because you're at risk of hurting yourself and other people with the noncompliance. And then, sometimes that's what a client needs to hear before they're like, okay, fine. And then they take it and then they get used to it. And then they're like, okay, maybe medications. There's a lot of different paths forward that could have helped. Anyway, going on. The defense experts, so the agency, and these are experts that would be working close with the malpractice insurance that I have. That is, the defense experts, they said that the client did not exhibit suicidal ideation. So the defense people are like, okay, when we look into it, we see, yes, it is true. The intern and the supervisor are in the right by asserting, okay, we had a client that died by suicide, but there was no indication of suicidal thoughts prior to that. So, what were we supposed to do? And the intern was assessing that every session. Now, we don't know the adequacy to that assessment, but, given the fact that there wasn't any ideation, the fact that the intern was asking at all is actually going above and beyond what other people would do. So the defense is like, well, we have a good defense that the client had not indicated any suicidal thoughts prior to that. However, the experts were critical of the intern and the supervisor for failing to obtain the client's psychiatric medical records. Right. Also, as is the case with a lot of these cases that I read on the podcast, the documentation for both the intern and the supervisor was insufficient. It's almost always the case. The case was determined by the defense lawyers as potentially having a really high jury verdict. And according to the brief, meaning that, in the civil suit, the jury would award the family a lot of money, and the malpractice and the agency and the counselor and the intern and maybe the psychiatrist would have to fork up a lot of money. And the factors that the brief identified were the client's age and this what they call the sympathy factor for that could influence the jury's decision. So the first one I don't know about. It sounds like what they're saying is, given that the client was young when she died by suicide, or on the younger side of things, that could cause more jury sympathy and thus a higher jury verdict. That seems kind of funny. It's like, so old people don't matter? I don't know. But this other one I definitely know about. The sympathy factor potentially influencing the jury's decision. And this happens all the time. Legal experts that I know of will tell me this, that if we just look at this objectively, the liability or the fault of the intern, supervisor, agency, it's up there, but it's not like astronomical, right? Given the fact that there was no talk of suicide, there have been no previous attempts. Yes, there was seemingly a manic episode that had begun that day, or maybe the early or the yesterday. They do have a scheduled session in 2 days. The client is connected with a psychiatrist, so under a lot of circumstances, you're going to see that reaction from interns and supervisors of just like, well, you're going to see her in a couple of days, so just wait until then and address it from then. I mean, as I say that out loud, I'm like, well, but they also would have had a safety plan, and anyway. So it's a pretty common. It's not like the intern and the supervisor were egregiously negligent in the situation. However, given the fact that she died, she's dead, and given the fact that there is some blame potentially that you could point a finger at the intern, supervisor, and agency and psychiatrist, the legal experts are saying juries typically will say you need to pay a lot of money because someone died in the situation. And the jury won't take into account the amount of blame that should be bestowed upon the agency. Am I making sense? Under quote unquote objective evaluation of the situation, you'd say, well, in terms of a percentage, what percentage would we say that the clinicians are at fault? And, given the limited information I get from this brief, I might say that the clinicians are, I don't know, maybe 50%. Certainly not 100% and not 90%, because there's some evidence given the profile, and there's no data, but there's some evidence pointing in the direction that the client was not complying with therapy. Wasn't, because if the client was really concerned and really on board, the client would say, hey, by the way, I was hospitalized, so we need to talk about this. Also, it's unlikely that the client suddenly thought about suicide. It's more likely that was going on and the client just was trying to avoid being hospitalized again. Who knows? I'm just making all this up, but there's probably data along those lines, and therefore there's not a lot that clinicians can do under circumstances like that. But anyway, so if the jury said, well, $1 million is what this is worth, and so instead of going to $500,000 that the agency has to pay, they would say that the agency has to pay the full $1 million just because of the sympathy factor. Anyway, I'm not a lawyer, so don't listen to what I'm saying. The defense lawyers predicted that they would lose in court, so they decided to settle, and they settled for, quote unquote, more than $200,000. So I'm guessing it's not much more than $200,000. So recommendations. These are my recommendations. This is what it's pretty clear from what I've been saying, but just to be clear, that agencies should have adequate policies about supervision and crises. It's pretty obvious, but I should put that out there. And the standard of care should be considered when establishing these policies, and this standard is very standardized. There's things in my field in therapy that we would consider to be the standard of care, but there's a lot of people at the edges, a lot of variability, a lot of differing opinions about this and that. But when it comes to these kinds of things, like the amount of supervision and whether or not you should have a crisis policy, the vast majority of agencies all agree that X, Y, and Z should be happening. Going on, another recommendation is that everyone should appreciate the importance of supervision. Agencies should appreciate it. Supervisors should appreciate it. The training program, because that's the other aspect here, is that there's a university involved, right? So you had the university, and I think a university clinic, and then you have this outside agency that was hired to supervise the interns. Well, what was the university doing to monitor the situation? Because I've been there before. I've had to go after agencies and say, hey, you need to be providing more supervision for this person. And if you don't, then our relationship is going to be harmed, and I'm not going to send interns to you anymore. And your bottom line depends on me sending you free labor, which is a whole other topic. It shouldn't even be free. But, it's not like agencies are rolling in money. It's more of a matter of tax dollars. But anyway, so everyone needs to appreciate the importance of supervision. And if the owner had appreciated it better, if the supervisor had appreciated it better, if the training program had appreciated it better, then I'm guessing there would have been a different outcome. At the very least, the intern would have had more supervision, more guidance. And a lot of the times, interns want more supervision. I mean, it's almost universal that interns feel, even with the model that I'm a part of, it's 5 hours a week. Interns are still looking at me, particularly in the beginning, and going, I have no idea what I'm doing. I need more time with supervisors and stuff. And so interns typically are asking for more, but they don't have the power to speak up. And even if they do, they often aren't listened to. So the blame is on the agency and the supervisor. Going on, another recommendation is that there needs to be better training for interns. I don't know if the intern was poorly trained or well trained, but the fact that she didn't know that pressured speech was a sign of mania, says something maybe. Hard to say. Also, there needs to be better documentation, which I always will say at the end of these ethics cases. Another is that there needs to be timely communication with collaterals, like the psychiatrist, particularly with high-risk cases. And I see I see the whole spectrum here. I see some people in my circle that are very diligent about connecting with other collateral contacts, whether it be psychiatrists or schools or parents or spouses or their physician, their dietitian. They're very on the ball, and it's just built into their week that they allocate the time for that. It's on their mind. They have their list that they keep track of. They document about it well. And then I see people the other end of the spectrum that literally never reach out to collateral contacts. And just go, what is it? I'll just do my own thing. And it's irresponsible on so many levels. And we see the result of the case. And by the way, I like this case because a lot of the cases that I review from my malpractice are so over the top ridiculous. Like, what was the last one that we did where the therapist had hired the client or had switched to becoming a life coach, and then the client moved in to the therapist's house, and then there was like a bartering situation, and it escalated from there. There are other cases that I've read where there's inappropriate sexual contact, whereas this case, this is the things that are outlined as problems in this case are much more common than the typical case that I read on this podcast. The problems that we're running into, especially the devaluation of supervision. I run into that quite a bit, where I'll have an intern who is at a site, or someone will hire me post-grad and they will tell me how bad their supervision was up until that point. That I'll have an intern that their on-site supervisor basically just chats with them casually. Maybe they'll meet for an hour, but it'll be all business stuff, stuff that you need to cover in supervision, like, are you up to date on your treatment plans, your progress notes, that sort of the nuts and bolts, if you will. And those are all things you need to cover. But I've had interns who will tell me that their on-site supervisor, that's all they talk about. They never talk about countertransference or psychotherapy theory or intervention options or stress management or new research or diagnosing or whatever. There's no talk along those lines. It's all just nuts and bolts. And I think it's because, well, there's a number of factors, and I've seen it all over, the 25, 30 years that I've been seeing this happen. One is that you have a bunch of supervisors that don't know what supervision really is because there's no required, or there's very little required education around what it is to be a supervisor. But also, you have a lot of supervisors who don't want to be supervisors, but they're forced to be supervisors because the agency needs someone to supervise, and they might be one of the only staff therapists that has the qualifications. And in order for that person to keep their job, they have to take on supervisees, but they don't want to. Another factor is that when you overwork people, then things are going to fall through the cracks, and you're not to supervise correctly, to be a therapist well and to be a supervisor well, you have to have a lot of energy, and you have to have a lot of brain space and heart space and the energy to dedicate yourself to the extras of being a supervisor. Like for me as a supervisor, if I just wanted to coast through my career, I could have done supervision the way I would see it done sometimes, which is just casually having conversations and going over their paperwork. And I would never get in trouble, and people would probably think I was a good supervisor. But I couldn't sleep at night if I was doing that. I care about my supervisees and about their clients. And so I would put the effort in, not because anyone was telling me to or I was trained to, but because I just wanted to. And so you have to have that kind of mindedness as a supervisor. And like I said, a lot of people are foisted, the job is foisted upon them, and they don't really want to do it first. Okay, so going on. And the last recommendation is that, of course, you need to have a good suicide risk assessment procedure and safety planning procedure. This drives me nuts. I can't tell you how many times I will have clinicians that come to me having worked in agencies. And by the way, there are a lot of agencies and supervisors that do this very, very well. So I'm not saying it's across the board, but it's not uncommon for me to see a situation where every time there's a suicidal client, the therapist or the intern is in a panic because they don't know what to do. It's sort of like, I don't know, this just popped in my head, but if you're a firefighter, when there's an actual house on fire, you shouldn't walk up to the house and go like, oh crap, what do I do? The solution is training and practice and procedure, right? Or the military, for example, it's reps. You got to run through the reps, and there's got to be very little left to randomness and even to decision making. And when it comes to suicide assessment and addressing risk, there should be as little possible left to you making a choice in the moment. It should just be something that's just a matter of routine. You just follow this flow chart. And I have actually developed my own for my supervisees because the available tools out there I find to be insufficient, because there's so many nuances to suicide. And you can listen to my whole deep dive. Part of the reason why I did that deep dive years ago was because I wanted to have a more robust approach when I was helping my supervisees. And so when someone would hire me as a supervisor, I would just hand them this tool and say, when you have a client that is even on the low end of the spectrum of suicidal thoughts, here is what you do. And there's a lot of nuances because every client's different, but at least the baseline, and it was pretty elaborate. It wasn't, like I said, that the common tools that I see are, well, I won't go into the old details, but they're pretty limited in terms of the guidance and the, you can still look at these tools as a clinician and say like, wait, what am I supposed to do? So there's that. And even with this tool that I give my supervisees, inevitably when they do have a client that presents with moderate to high risk of suicide, the intern or the supervisee will still have tremendous anxiety and quote unquote not know what to do. But it doesn't take me long to kind of nudge them back into what we've already repped a bunch of times. You know what I mean? Anyway, so that clearly was not, or that seemingly was not being done, or it wasn't robust enough. And hopefully that agency has changed their ways, but who knows? All right. Well, stay ethical out there and stay classy, San Diego, and take care of yourself because you deserve it. You really, really do.